Hello, my name is Roberto Acosta, and this is my volunteer patient, Ms. Daniela. We are going to be performing a thorax, lungs, and cardiovascular assessment. So here we go. So starting with the interior of the thorax, we always want to start with inspection, and in order to do that, we must be able to clearly see the entire torso. So assuming that the patient has a gown on, we must move it, but always making sure that we protect the client's dignity and privacy at all times. So I'll start by simply observing the client's breathing for a few breaths. I'll ask the client to put her hands to the side. Yes, thank you. And I want to make sure that there are no signs of distress, no abnormal breathing, that the chest is expanding equally, and make note of the general rate and rhythm of the breaths. I want to note if there are rapid, shallow, or deep. Next, I want to inspect the shape and symmetry of the thorax and establish what is called the AP diameter, which is basically the measure of the anteroposterior diameter, which is the front of the chest to the back, versus the lateral diameter, which measures from the left to the right of the interior view. Normally, and so if I could ask you to sit up really quick. So anteroposterior would be this measurement here, compared to this measurement here. Okay, thank you. Sit back down. So normally I would see an anteroposterior diameter that is less than the lateral diameter. If they are closer to being equal, it could be considered a barrel chest, and this is typically seen in a large segment of COPD patients. So lastly, I want to inspect the color and condition of her skin and make note of any redness, lesions, or cyanosis, which clearly she doesn't have any. Now I'm going to move over to palpate over the chest and to feel for any crepitus or crackling under the skin. This can indicate any subcutaneous air, and which sometimes is caused by trauma in the lung. So I'm gonna go ahead and palpate, okay? Another important thing to consider is being able to hear for any auditory or advantageous sounds just with the naked ear prior to doing any auscultation. Now I'm going to percuss by using 2 fingers from each hand and gently tapping in between the intercostal spaces from the apex and down. So moving from left to right, I should normally be able to hear resonance or any dullness. This can be an indication of fluids in the lung, or it can mean that you are actually percussing over the liver or the heart. Of course, we would ask the patient if she feels any pain or tenderness, which you don't. I should note the importance of asking the patient or client to, if they have any pain or tender areas prior to percussing or even palpating. So in this case I didn't, so I apologize. But now I'm going to move to auscultation, make sure that I, again, make note of any audible sounds with the naked ear. Such things as wheezing or coughing or stridor are actually auditory without a stethoscope. So I will use my stethoscope to listen in between the 10 and 12 intercostal space. I will start at the apex and work my way down, moving from left to right in a methodical fashion in order to compare both sides. So I'm going to ask you to simply take a breath. And every time that you feel my stethoscope move from one position to the other, if you can just take a nice and gentle breath in and out for me, okay? So nothing too big, but just so that I'm able to hear the air movement every time that I move my stethoscope. Deal? All right. So asking the client to do this will prevent from having to asking them to move every single breath, which can interfere with the auscultation process of it. I want to make sure that I also listen to the mid-axillary regions so that I can listen to the middle lobe, especially on the right side. So I'm just gonna, this might tickle you, but I'm gonna listen right, okay, you know. Now that I finished the anterior side, I will ask the client to sit up so that I can assess the posterior. The easiest way to do this is just to simply have the patient sit up. For efficiency purposes, I can go ahead and auscultate the posterior side while I still have my stethoscope out. I will use the exact same technique as the anterior, except I want to avoid the shoulder blades, but still listen from side to side. So the same thing, whenever you feel the stethoscope move in position, if you can take a breath in, yeah?
Okay.
All right. Very good. So, thank you, you could sit back down. All the breath sounds are clear. Lungs don't sound diminished. There's no adventitious sounds like wheezing, stridor, crackles. So, I should be able to hear bronchial followed by bronchovesicular and vesicular sounds. Again, it's important to make sure that we listen for any advantageous sounds like crackles or wheezes. I'm actually going to have you sit up again because I'm still working. I'm sorry. I'm still working on the posterior. Now, when I'm looking in the posterior side, I'm looking for the same type of findings that I did in the anterior, which is symmetry, expansion, and skin color, any scars or any lesions. Now I'm going to go ahead and move to palpate, and I want to feel for any crepitus, just like the anterior. So if you can just take some, not deep breaths, but just enough so that I can feel the movement. I'm looking for a couple of other things that I want to look for here in the posterior. First is expansion. I want to place my hands on the lower rib cage with my thumbs touching each other, and then ask the client to take a deep breath. And I should be able to see my thumbs move over, away, and back equally. So, there you go. So now this one's take a big deep breath. Ready? One more time. Good. All right. Now I want to check for what is referred to as tactile fremitus, which is a vibration in the chest that is present when the patient talks. So using the backside of my palms, I will feel in about 4 to 5 different places, starting at the apex, moving downward on both sides, while the patient says the word 99. Okay, so every time my hand moves, same thing like the stethoscope, say 99.
Okay. 99.
A little louder.
99.
There you go.
99. 99. Thank you. 99.
And one last time.
99.
Okay, thank you. So now, in regards to that part of the assessment, vibrations should be equal on both sides, and any decrease in vibration can mean there is some fluid consolidation. So now I will finally do the percussion part of the posterior thorax. I'm going to do this in the same fashion as I previously did in the anterior. Again, I'm looking for any resonance while making sure to avoid the scapula. It's important to remember that hearing any advantageous sounds could mean that the client is having difficulty breathing or difficulty oxygenating. So this one I'm just going to be tapping on your back, okay? Sounds good. Now you can sit back. So now I'm going to move on to the next part of the assessment, which will be assessing the heart. I will start with taking a manual blood pressure and establish a heart rate. So please hold, because I don't have my So I'm gonna go ahead and grab my manual blood pressure cuff here. So we, in regards to this assessment tool, we want to make sure that we are always using the correct size of blood pressure cuff for each particular client. The length of the bladder should be at least 40% of the client's upper arm circumference, okay? So basically, and a lot of these have indicated in them if they're for adult. Yeah, so on this, I'm gonna be reaching over a little bit, okay? So grab our stethoscope. We're gonna put the diaphragm of the stethoscope right along the brachial part of the left arm. The blood pressure cuff here indicates exactly where the placement goes. So typically, you want to make sure that you tell clients to not talk or laugh during the blood pressure taking, because it does compromise the test. So if this were, it should be, but you couldn't laugh or talk. And if it does, we would have to redo it again, okay? Thank you. Okay, now, we're going back to inspection. So we're going to be looking at the level of the jugular venous pressure, JVD, which is done by measuring the highest oscillation point of the jugular venous pulsations. So on this one, I'm gonna actually ask you to sit a little bit more up. There you go. So now moving to the inspection of the chest wall. We see that her chest doesn't reveal any deformities. There are no obvious visible pulsations around the apex of the heart. Her chest inspection also does not show any midline sternotomy, which can indicate history of CABG, which is common in older clients. There's no indication of inferior clavicular or scars in the precordium, which would mean presence or history of a pacemaker. And also no pectus excavatum, which you would see basically an indentation in the center of the client's chest. So a very normal chest here. So now I'm going to move to the palpation part of the assessment. I'm going to be looking for the PMI, which I will do by looking at the client's clavicle. And so finding the first rib, which is right under the clavicle, I move down and find the soft spot, which is the first intercostal space, and move down my fingers down down to the apex of the heart, which is located at the fifth intercostal space, mid-clavicular line. So let me establish that first here. 1, 2, 3, 4, 5. So the fifth intercostal mid-clavicular space for a female would be right below the breast area. And so at that point I will use my stethoscope and place it right at the apical site and listen for a full minute while I count heartbeat. So I'm just gonna go ahead and place this here, okay? So now if I hear a regular heartbeat, I will basically count the heartbeats for 30 seconds, multiply that by 2, and then I would establish a heart rate. Adults' normal heart rate is between 60 and 100. Now I'm going to palpate for any thrills or heaves. So first I'll fill in the mitral and tricuspid areas, which basically I would put my hands in a horizontal fashion. And again, I'm trying to feel for any thrills or heaves, which would you be able to palpate here. Now I'm going to palpate in the aortic and pulmonary areas, which would basically be by virtually placing my hands. And again, if there's any heaves or thrills, that's something that you'll be able to palpate. Now I'm going to palpate the carotid arteries, and I want to do this one at a time to prevent disruption of circulation to the brain, and therefore causing the client to possibly faint or get a spell of dizziness. So if you can just come, actually we'll do, just look a little bit to your left, not too much. Yeah. So I want to note the rate, rhythm, and quality of the pulse, which is in this case are palpable +2 on her left side. Also palpable +2 on her right side. Now, another way to measure for heart rate is by using my watch and keeping my 2 fingers on the carotid artery, counting each pulse, again 30 seconds if it's normal, multiplying that by 2, and then getting a result. Now I'm going to move over to the auscultation part of the assessment. Some basic information about the stethoscope is there's 2 heads on it. You've got the bell and the diaphragm. The bell is mostly used for low-pitched sounds, and the diaphragm is useful for all of the different pitches that are within the heart. There is an acronym that is Many Things Are Possible, MTAP, which is used to, it's helpful in remembering in which sequence the valves are closing. And it's also helpful in determining the etiology of murmurs and, of course, where they are located. So basically, the M would be located right down here in the 5th intercostal midclavicular. We would have the T right next to it. So we got mitral, tricuspid, and then we would have A, and then we would have, which was aortic, and then we would have, so it'd be M, T, A for aortic, and then pulmonic over here on the right side. Going back to the stethoscope, it helps us listen to a particular 3 phases of the cardiac cycle. First, we have the heart sounds, which are S1 and S2. S1 sounds like lubbed up. And then you have S3 and S4 sounds, which would be the gallops, if there are any. And then second phase of the cardiac cycle, which would be systole, which is the space between S1 and S2. And then we got diastole, which is the space between S2 and S1. And so as I move my stethoscope across the precordium, the first thing that I want to do is to differentiate between the systole and diastole, which can be done basically by palpating the right carotid artery here, and then as I auscultate simultaneously at the base of the heart and compare the sounds. I want to keep in mind that each carotid upstroke coincides with one cardiac cycle, and therefore also one full systolic and diastolic cycle. So basically, like the first sound that you hear before the carotid upstroke is S1, and then the following sound is S2. That really doesn't mean a whole lot to you right now, but to me it does, so. Alright, so basically I'm gonna establish her right carotid here, and then listen down here at the and again the S1, S2, it's lubbed up, and it's basically that in that cadence as well. Another part of the auscultation is auscultating the carotids and listen for any bruits. The carotids are on both sides here, located in between the trachea and the sternomastoid muscle. For this particular part of the assessment, I want to ask the client to take a deep breath and hold the breath while I listen to one carotid at a time. Again, we want to make sure that we never do both carotids at the same time. So I'm going to basically place the diaphragm on my stethoscope and listen to your carotid, okay? So just take a deep breath, hold it, and then that way I can get a clear sound of your carotid. I'll do your left first. So,
Okay,
yeah.
got it.
Ready? Now, to identify first and second heart sound, we can best hear the S2 sound up in the aortic area, which is right up here. And S1 can be heard best in the mitral and tricuspid area, which would be down over here at the base of the heart. I want to make sure to listen with the diaphragm of the stethoscope because both of S1 and S2 are higher pitch sounds. So I'm going to listen first to the mitral and tricuspid area. So you don't have. Is that we're listening here at the pulmonic. I'm sorry, aortic on the left side, and then the pulmonic is over here on the right side. Sounds good. Now another thing to consider when auscultating is that normally when a person is breathing, which is also referred or can be referred to comfortable tidal volume breathing, the mitral and tricuspid valves, which are located here, are almost closing perfectly simultaneously. However, the aortic and pulmonic valves actually separate or split during the respiratory cycle, specifically during the inspiration. So basically what happens is this, S1, which can be represented here by my right hand, so you have a mitral and tricuspid here, and then S2, which is represented by my left hand here, which you got the aortic and pulmonic. So when a person takes a deep breath, the aortic and pulmonic actually separate like so. So basically, this is what they would look like. And that is considered normal physiology in people. So this is driven by the fact that when you breathe in, you're actually creating a negative space in the chest, which consequently draws more blood to the right side of the heart. So basically, that means is that on auscultation of your heart, I heard normal S1 and normal S2 with no added sounds. I also did not hear any carotid bruits or any murmurs. So that completes our assessment. Thank you.